Good afternoon, friends. This will be a course on DMEK Med Simple for the beginners. And I am Dr. Shamor Bashak from Kolkata, and there are other co-instructors with us. Dr. Rajesh, Dr. Namrata will be joining soon, and Dr. Revati Rajaraman. And we have our guest faculty, Dr. Audrey Rostov. She is from USA, and she looks after the skill transfer courses in India in many places. So she will be giving on DMEK versus DSEK case selection and complex cases. Dr. Audrey.
Thank you so much. Where's this? Thank you so much. It's a pleasure to be back here in India and face-to-face to see everybody again. These are my financial disclosures, none of which are relevant to the presentation. So to DMEK or DSEK, that is the question. How do we decide? DMEK, as we know, yields better vision, quicker recovery, less rejection in the select cases. Patient considerations, though, need to be considered, such as the age of the patient, the cornea status, is there a previous PK, the lens status, current IOL status, is there a history of retina surgery, and such. For DMEK, I find that the straightforward cases work best here. Those with an isolated endothelial issue, such as Fuchs or pseudophakic bullous keratopathy, minimal stromal edema, a patient, for example, who may have a multifocal or an EDOF lens and then requires some sort of endothelial cell replacement, these are perfect for DMEK. More challenging cases include those with deep anterior chambers, such as high myopes, those with previous retinal surgery like vitrectomy. Also, you need to assess need for IOL exchange. This is also a more challenging case, and also post-PK. For cases that are more appropriate for DSEK, this would include patients who have large iridectomies, aphakia, glaucoma shunts, or present of ACIOL. DMEK requires a good view. And so to make life easier for yourself and your patient, if you have a good view, then a DMEK is a really nice option. DSEK you're able to do with a really cloudy view. I look at a DSEK as basically a slam dunk in a lot of these complex cases. Oh, sorry. Can we get rid of that? I don't see that on my screen here. It's not on my... No, I know, but I don't see it over here. I'm so sorry. I don't see it. Apologize. Uh-oh. Okay, there we go. That's a lot easier. Thank you. And it's now not advancing. Sorry, it's, apologize here. Let's try this. There we go. When we have patients who have a previous cornea transplant, a previous PK, and especially if you have someone who had, say, a TPK and not an optical PK, this is someone where an endothelial keratoplasty makes a lot of sense. It's less invasive. You can get good vision recovery, of course, if it's appropriate. In EK after a failed PK, of course, it's less invasive. If you're doing a DSEK, you don't have to strip Descemet's membrane. For a DMEK, you do, in fact, have to strip Descemet's. You want to be sure, though, that you avoid the graft-host interface and junction there because you can pull it apart. And I also like to use a smaller graft as well. Let's see here if this video is working. Yeah. Great. Don't know why it doesn't work on my screen. Anyway, in case of a previous cornea transplant, I always like to measure with calipers. You want to make sure that your DSEK or DMEK is a smaller diameter compared to your PK. And I like to undersize by about 1 millimeter. So if I had a previous 8 millimeter PK, then what I will do is do a 7 millimeter graft. For DSEK, you can strip about the same size, and for DMEK, I go slightly larger. That's why I mark. And whether it's a DMEK or a DSEK, I still do the same thing. I make my 3 paracenteses, and I really like to have this little Decimase membrane stripper, this Desmetorexis forceps. And it just does a really nice job of being able to both score and remove Decimase membrane. The nice thing is that if there's pus, if you have the synechia there, it's very, very gentle. Synechia are best managed being cut rather than pulled out, because then you can get an intraocular hemorrhage, and that will make life more difficult for yourself. You can see how Decimase membrane just comes right out there. Again, I like to undersize my grafts for EK by about 1 millimeter, and that works very, very well. With a DSEK, in this case, I like doing just a simple 30-gauge push-in technique. You always have a 30-gauge needle. I don't use a glide unless there's a large iris defect. And then I go on top of the graft on the stromal side with a little BSS, irrigate that, and then the graft opens nicely, as you can see here. For a DMEK, it's essentially the same as any other DMEK that you're going to do. Here we have the DSEK, and then suture the wound, of course, and then I add, and I put in usually a little bit more to secure the wound, and then adding a nice air bubble. With a DMEK, it's basically the same. What you want to be sure of is that if the graft won't unfold, it's either upside down or there may be fibrin in the way. If you do too much tapping, you're likely to get some fibrin, and so therefore you just want to watch that. Either way, though, you can get a very, very nice result. Here's an OCT and a clinical photo. You have to be careful, though, with your air bubble management for both DSEK and DMEK in a previous PK. This is a case where there's a rupture of a graft wound. So this is the previous PK, and there you can see that ruptures. It's not that big a deal. I mean, you can, of course, go and resuture your PK wound, but it is a bit inconvenient. When you have a patient who has a large iris defect or aphakia, I like to put in what I call a stay suture, and this is suturing the donor lenticle to the previous PK, and you could see in this case where there was a detachment that the only thing holding that lenticle in place is in fact the single stay suture. Here's the, and I'm trying to do the video here. For some reason, it's not going. Anyway, this is a case where I'm showing a, let's see if we can get this to go. This case here, still not going, that's all right. It's a case where I have to do a superficial keratectomy. I am now removing the a hazy foul DSEK graft within a PK, lack of iris, and I put what I call a secure or safety suture. You can do a suture guide, and I apologize for the, let's see here. It's working on my screen, but obviously not up here, so we'll just go on. And now that appears to be kind of stuck. Sorry for the for some reason, it won't advance. It's just frozen here. Yeah, it seems stuck. See, it's going here, but not there. That you're just moving the video around on the slide. See, it's not, sorry. Okay. It's also, I uploaded the thing as well. It's uploaded there as well. Let's see. Oh, here we go. Okay, that's fine. And so this is what it looks like post-operatively, that same case. It's not moving here, but I'm not going to worry about it. All right. This is a case in terms of looking at a previous DSEK. When you have a failed DSEK and then you decide whether you want to do a DSEK or a DMEK, I like, again, using this nice little Decimase stripper, and you can easily just remove that failed graft. And in this case, again, repeating the using the DSEK replacement graft. So if you have a failed DSEK, do you do a repeat DSEK or a DMEK? Well, again, that depends. There we go. It's always nice to have IT challenges. If it's graft failure or a traumatic DSEK, if it's a younger patient, a phakic patient, and there's a good view and minimal coexisting morbidity, then I like to replace a DSEK actually with a DMEK, and that really works quite well. If there's a more challenging view, if there's an ACIOL, iris defects, previous retina surgery, or a glaucoma tube, then I'll tend to replace it instead with a DSEK. If there is an opportunity to need to do an IOL exchange, for example, sometimes what I actually do is if there's a displaced ACIOL, I'll remove the ACIOL that's causing the problem, and then I'll put in a DSEK graft, let things clear, and then after that, following that, I'll go ahead and do a scleral fixated IOL. The scleral fixated IOL then will have a very, very nice view, so you can actually see well enough to perform that. Due to time, we'll interrupt that video. Again, with a DSEK, if there's a well-placed ACIOL and that's stable, then you don't need to replace it. But if, as in the upper picture, there is some issues there, then it's best to replace it. Glaucoma tubes, glaucoma shunts. When I first started doing DMEK, I would do DMEK on absolutely anything and give it a go. However, we know that with previous glaucoma tube shunts, your life of your endothelial keratoplasty is only really about 3 to 5 years, and so I just do a DSEK now. Otherwise, it's expensive potential wasting of tissue, and they only last a few years anyway. So in summary, DMEK, if you have a good view, previous PK, phakic, or a failed DSEK with minimal comorbidities, I like to do a DMEK. And a DSEK I reserve for more complex cases. DSEKs are very, very straightforward, and you can give a very, very nice result, even in the most complex cases. Thank you so much.